Yes.
Definition of gorked out is?
Altered LC or V on the AVPU scale.
Dustin does a good job of being gorked out right there. I mean, it's not really anything different, but
That's his baseline.
so ABCs, you manage your ABCs, history of present illness, so events leading up to onset, acuity, your past medical history in regards to hypertension, stuff like that. Oh, weird. Blood glucose levels. Why do we want to check blood glucose levels?
To make sure it's not a hypoglycemic
Oh, and
incident.
make sure you're not rolling in with a stroke alert and like. Yeah, psych, I got you good, sucker. Right? That's actually that was actually one of my concerns when I took my mother-in-law in the other day. I'm just like, oh man, I don't want to be one of those. Like, I almost like detoured and pulled into station 11 just so I could check her sugar to make sure. I'm like, yeah, I'm pretty sure she's super sick, but you know, I don't want to roll in with being one of those idiots that's like, hey, low blood sugar kind of thing, right?
Does she have a history of diabetes?
No, no. All right. Consider code 3 transport. Yeah or no?
Yes.
Or no?
Yes.
Is she dying?
Time is muscle.
She dying potential? Yeah. Times muscle, times brain tissue. Complete your neuro exam and route. So if you're going to complete your neuro exam and route, then how do you know that you're going to go code 3? Why would you go code 3 if you haven't done your neuro exam?
Can we just do it before?
Because you had a high index of suspicion.
And why would you have a high index of suspicion?
Because you saw some of those signs and symptoms that you're
Yeah.
going to complete on your neuro exam.
So if you end up with a couple of these things, like, hey, you got left side arm weakness, be like, hey, I can't do anything like that. It's like, okay, cool, let's load and go, let's get this going. This is more than likely a stroke alert. We're gonna start heading in that direction, and then you're gonna finish your full detail.
You're going
You can
to
always
call
call
in
it
your,
back.
are you going to call in your stroke alert before you finish your?
Nope. I'm gonna get my entire neuro exam done before I call it. So I'm gonna have my full set of vitals, full neuro exam before I make that.
What's included in the full neuro exam?
You will see.
Great.
With just this much patience, Mark. That's all I'm asking for. Just this much patience.
And then you call in.
Just making sure, like, sometimes the slides,
Sometimes decides we don't get there, right? Right, so then I guess we'd be here tomorrow then too, and then the next day, and the next day.
there's some things on slides I don't understand. And
Right.
if I don't ask,
I know,
then-
I appreciate you just stop asking. Okay?
but I'm here to learn.
All right, so TIA, we talked about that. All right, so here's some of our neuro exam. We have multiple different assessments that we're gonna perform, right? We're gonna perform every single one of these on your patient. Yeah?
Sweet.
Or no?
Yes.
Yes. Oh, thank you, Andrew. Man, so confident. Love it. Right? So you got your GCS, you got your cranial nerves, cerebral, cerebellar, and your cortical function. Okay? So
You gonna go
your
over all those?
GCS. Huh?
No.
What?
You gonna go over all
Yep,
those?
we're gonna go over all of them.
Thanks.
We've got a full hour to go over all of them. Okay? We'll hit it.
Stop
Patience. Like just this much patience. Okay? Okay, so GCS. We all know how to do GCS, right?
Yes.
GCS becomes very, very important when it comes to your stroke assessment, okay? Because we use this in part of our CSTAT alert stuff.
What's CSTAT?
Oh, we're gonna get there, dude. Pete's sakes, dude. You're killing me, Smalls. All right?
Where's Chandler?
So our CSTAT is down here in our, it's supposed to be cortical function.
Cortical.
Okay, so GCS, we all know how to do GCS. We're gonna bust that out really quickly, right? You guys are so good at doing GCS now. Right, Andrew?
Oh, yeah.
Josh? Yeah? Okay, Levi? Okay, good, because this afternoon is gonna be, you guys are gonna be on it, okay? All right, cranial nerve functions. Okay, so when we go to perform our neuro exam, these are all things that you are going to complete on your neuro exam with every single patient. What you guys need to do is you guys need to create a systematic approach so that you take the same approach every single time so that you do not forget one of them. Okay? We perform every one of these on every stroke assessment. Okay? And this is only just this small little part. Okay? Got it? Piece of cake, right? All right, raise your eyebrows. Exactly. Okay? So what are you looking for?
Equal.
Symmetrical, right? So the way I approach it, you start at the top and work your way down, right? So by doing that, it's going to keep you from bouncing from here to here to here to here, bouncing all over the place, right?
Do you remember all the cranial nerves and what they
No.
go to?
I already talked about that. We talked about that like months ago. right?
Now we're assessing for all those cranial
We
nerves.
are assessing for them, but the only thing we're really truly assessing for is deficits in relation to them, right? If there's deficits in relation to it, it's something that it's like, hey, there's a red flag, that's positive for our stroke assessment, right? I don't care what nerve it affects, but I do care that there is a nerve affected, okay? All right, so you get your raised eyebrows, close your eyes. What do we do with the close the eyes? No, this is not closing your eyes, Lindsay. Are you fast forwarding, not having patience? Just getting looped on there? Maddie, close the eyes. What does that mean to you? Hey, close your eyes. Hey.
It's
Is it like that? Is it like this? Is it just closing your eyes?
It's like closing them really tightly.
Right. So you're looking for them to grimace almost, right? So squeeze it real hard. Once again, so people that are having asymmetrical, so they'll basically have one that's really, really tight and one that's kind of loose looking. You're looking for symmetrical scrunching of the eyes, all right?
What if they have big long eyelashes and you can't tell?
So you reach up there and either you pull them off, or you just take your little trauma shears and be like, hey, here we go. Okay.
I don't know.
These are real.
Okay, here we go. Follow your finger with their eyes. Okay? So, you take your finger out in front of them. Okay? So, Dustin, you're going to do this. I want you to keep your head still. Don't turn your head. Follow just with your eyes. Okay? And so you start following it. Now, see? You get, and then you smack them, right? So say, hey, follow my finger. Here we go. See, he's automatically trying to turn his head a little bit,
I
right?
tried, I stopped.
Okay? All right, there we go. So you take it all the way to the point where they can't go any further, and then you're looking for nystagmus, a little bit of nystagmus right on the edge, right? So when they get to that far edge, if their eyes start twitching, that's a potential positive finding, okay? And then we're going to come back.
Is a positive finding?
Yeah. Okay? And so some people have a natural nystagmus. So, you know, when they're, I don't know if anybody's gotten a Dewey before, but when they check your eyes, that's what they're looking for. They're looking for a nystagmus. Some people have natural twitches. As you're going like this, the eyes are going all the way back and forth, okay? So you're moving it, you're going back and forth, and you're checking for it. All right?
So if you're looking for nystagmus, and some people have a natural
Nystagmus.
is that just one finding, or is that, how many of these are we using?
So you can use one and only one of these to do a stroke alert. But more than likely, if you have one versus, you're going to have a couple of them.
That's my, yeah.
Yep, most of the time, because what's going to happen here is there's a couple other ones that are going to affect the vision here in a second, that some of their ability to use their vision and stuff, and so that will tag on to this one and be like, okay, I got a couple of these built now. All right? Show me your teeth and your smile, right? Big smile, teeth, right? People hate to show their teeth. It's funny. Like, hey, give us a big smile. It's like, no, that's not what I was like, I need to see the corners of your mouth. I need to see if one's going up, if they're going up symmetrically, right? Stick your tongue out, straight out. You don't want it to go down, you want it straight out, okay? You're looking for deviation left or right. All right? Say ah, oh geez.
I have a question about that. So when you have tongue deviation, is that towards the side of weakness?
It's all just going to depend. It's all going to depend on if you have an hemorrhagic stroke or just a minimal stroke, but most of the time, so anything related to the head or face, depending on which nerve it's affecting, most of the time it's going to be, so if it's the tongue, so if you have a bleed on the right side, you're going to deviate to the left.
Right. So it's on the opposite side.
Mm-hmm.
So similarly, if you have tongue deviation to the right, you are also going to have right-sided arm weakness.
So it's opposite. So your brain, so if you have right side deficit on the right side of your brain, it's going to be left side affected with the rest of your body.
Got it.
Okay?
So the reason the
Same
tongue is
face.
because it's pulling on both sides, so if it stops pulling on the left, then it's gonna deviate to the right, because only the right side is pulling.
But some cranial nerves.
So the right side of your face, think of it like all you have paralysis on the right side of your face
Yeah.
then. And so it stops working, right?
Right.
And so you still have your muscles on the left side of your face that are still working.
Right.
Say ah for your uvula, right? Ah, look all the way in the back of the throat. What's gonna happen back there? What's it do?
Usually,
Does it go forward, backward, side to side, or is it just
deviated to one side.
Right. And so you're looking for just deviation. That's one of the common ones that gets missed, and that's just another one of your documentation things. Shrug your shoulders. Boom. How you gonna do a shrug your shoulders test?
Can you touch your shoulders to your ears?
All right. No, so it's not just to shrug your shoulders, okay? So you actually gotta, I know, touch a patient. I know you guys are terrified of it, right? James, you care if I touch you? Nope. All right, cool. So if I'm assessing, it's like, hey, I've done all the facial stuff, I've had him go, smile, done all this stuff. So now I'm doing my shoulder check, okay? Be like, hey, I need you to shrug your shoulders, okay? And you're pushing down on his shoulders, trying to prevent him from shrugging. Now what am I checking? What am I testing?
Strength.
There. Because I'm going to see unilateral weakness if there is an effect on the shoulders, right? So he tries to shrug and he's like, hey, I can only get one. So most people can shrug their shoulders if they're having a stroke with no resistance. But as soon as you put resistance on it, you're going to see that unilateral weakness occur. Okay? And then your facial touch. Right? So you have facial touch. How's that work?
You touch the face. Do you feel this? Do you feel that? Okay, what's
It is kind of like that. Yes, Blake?
Is that what you do?
No, that's not what you do. You don't caress them. I know you're getting excited back there, Blake. Right? Okay, so when you're checking unilateral, okay? So you check 3 different places. You check forehead, cheek, and lower jaw. All right? But what you're doing is you're checking right side, let's see, left side, right side. I'm trying to flip this back on you guys, right? So left side, right side. So you're checking both sides at the same time. So, hey, does this feel the same as this? Does this feel the same as this? Does this feel the same as this? Right? So you're going from one to the other, and you're checking to see if they feel the same, sensation-wise. All right? So you work all the way down, touching the face. Okay? Any sort of abnormal finding says, no, hey, this feels a little numb in my jaw. That's another positive finding. Right? So all of these are things that potentially can tell you, yes, this is a stroke alert. If you have a positive finding on any of these, you have that potential for a stroke alert. Make sense? So you got a lot of stuff here to remember, and that's just from like here to here, right? We haven't even moved on.
Those are all the cranial nerves?
Yeah.
Shoulders are part of the cranial nerves?
Yeah, accessory.
All right. So now we have our Cincinnati stroke. Get your FAST, right? Face, arm, speech, and time. Facial droop. Right? So we did a little bit of assessment with that with the smile. Right? Sometimes you'll just walk up and they're just like, "Rrr," and you're just like, woo. Right?
Enough said.
Yeah, enough said. It's like, hey, we're there, right?
That's where you're going, then you finish.
Yeah, you're like, you walk up and so most of the time what I do is I start with this one really quick because it's a quick, hey, give me a big smile, okay, yeah. And as I'm talking to them, I'm checking for that slurred speech. And then I'm like, hey, let me check your arms real quick, right? So I grab their arms, do a quick little arm check, feet check, and that gives me my baseline. And then I get into more detailed neuro on the way there.
If you don't have signs on your stroke, your Cincinnati stroke, your FAST, are you going to continue with your others?
Yes, absolutely. Because people will present with that numbness on one side or the other, and those are the ones where it's very hard to find. So that's why when you have somebody that you're like dizziness, anybody with dizziness, you've got to do an entire exam to attempt to find and rule out worst case scenario.
Okay.
Is this like are we staying here, or are we getting going right now?
The question is did you find something here?
So I'm like saying, yes, you find something, you're like, okay, let's get going.
Yeah, we're gonna get going, right?
As opposed to, no, let's stay here.
Yeah, so that's why I do these ones first, because these are the big ones that are gonna tell me, hey, red flag, this is a stroke.
Let's get going.
Let's get going, hey, start moving. And then I do all the other ones as confirmation, right? So obviously if you have facial droop and arm weakness, right?
Let's load
It's
it.
like,
Let's get going.
you really don't need a whole lot more, but now you're just doing additional exam to see just how much of a deficit there truly is, right? Arm drift, how do we do an arm drift?
Close your eyes.
Oh, I like this,
Arms
zombie,
up.
let me see your hands. Boom. All right, palms up, okay? Palms up, keep your eyes closed, keep them there, okay? Keep them there, keep them there, keep them there. Oh, right? And so how long do we keep them? 10 seconds. So let's say like 6, 7, 8, 9, 10. I mean, didn't go all the way down. What do you think, positive or negative?
Positive.
All right, you do this again. Let's try that again, right? All right, hold them there. Don't let them fall, don't let them fall. All right, 10, 9,
That's pretty heavy for him, though.
7, I know, 6, 5, 4, 3, 2, 1. That's all that you got. Positive or negative?
Positive.
Did it happen twice?
Yeah, so same arm, same effect, same general location, so it's positive on the arm drift, all right? Speech, can't teach an old dog new tricks. Have him say that.
Sunny in Cincinnati.
Huh?
What?
What was this, Cincinnati, what?
Always sunny in Cincinnati.
It's always sunny in Cincinnati. Peter Piper picked a peck of purple peppers.
It never rains in Hudson.
It never rains. Oh, yes. All right, I'm gonna start that one.
I've always done that one. It never rains in
It
Hudson.
never rains awesome, right?
I'm a speaker
So when you do the rods that can't teach an old dog new tricks, what do they? If somebody's having difficulty, what's the first thing that they try and say?
I can't talk.
No, can't and tricks come right at the beginning, and then they stop themselves, and then they try again. Can't, tricks, dog, tree, right? And so they bounce all over the place. What's important when you're asking this kind of question?
Their understanding of what you want them to do.
Exactly, right? What's their normal mentation? What's their normal baseline, right? Are they completely comprehending, I need you to repeat exactly this, right? How many times are you gonna make an attempt at this?
Once.
Once, maybe twice.
Yeah, twice at the most, right? If they can't do it after two, either they just can't do it, or physically because of a stroke they can't do it, right? So what do you think so part of that past medical history, part of that overall mentation is gonna guide you on making the determination of whether or not that's a positive or a negative. And time of onset. How important is this to us?
Really important.
In the last 3 hours.
Less than what?
4 hours?
6.
6.
Less than 6.
Damn.
So it's gotta be less than 6 hours,
I'm,
or a wake up. If somebody wakes up feeling that way,
You don't know how long it's been.
right. So that is for generalized strokes. C-stats are something completely different, right? So we have C-stats, which we will cover, that kind of cover a little bit more of the stuff, okay? How do we document this? How do we relay that information to the doctor? Hey, this started at 6 p.m.
Last known well.
Okay, last known well at 6 p.m., right? Do we put, what? 1800. It's always in military time documentation. Okay, so it eliminates any sort of confusion on documentation and that onset. All right. How about if somebody is on Coumadin? Does that do anything to our stroke alerts?
Speeds it up.
It used to be a contraindication for stroke alerts because of the fact of the anticoags and stuff like that, so they couldn't give thrombolytics and stuff like that to it. But they've since pulled that out, and it's now just hey, we need to know whether or not that they are on blood thinners. Okay, so that's one of the main questions in your past medical history and present illness presentation is whether or not they have those blood thinners on board. All right, and if they've taken them at the appropriate time. So, all right. Finger to nose. All right, so here we go. Finger to nose. All right, so what we're gonna do here with the finger to nose test. All right, square up here, Mark, please. All right, so this is what I want you to do. All right, I want you to take your right hand, touch your nose, and then touch my finger. Okay, nose to finger. Nose to finger. Okay, nose to finger. Okay, good. Now use your left hand. Nose to finger. Nose to finger. Nose to finger. Nose to finger. Okay? So you're moving it across both left hand and right hand. And what you're looking for is if I'm going to try and touch Dustin's finger, okay? No, yeah, there you go. So I'm touching my nose, okay? And now I'm trying to touch his finger. What you're looking for is you're looking for this, okay? You're looking for jerkiness, and you're looking for inability to. A lot of times you'll get something like this where they'll be like this, and then they'll be like that, right? Is that good or not?
No.
No, absolutely not. So we're going for this, and we're going for that, right? So each time it's boom, and as that's moving, most of the time as it moves, so the first time they may be okay, but then they're like, as they see it move, now they're trying to do this, right? And they'll kind of do like almost double taps, trying to get it. All right, positive or negative finding?
Positive.
What do you need to know about past medical history?
baseline.
Yeah, baseline. Does this person have Alzheimer's? Do they have Parkinson's? Do they have something that's going to attribute to? How about a 90-year-old female trying to do this? Can be difficult, right?
Yeah.
Maybe, maybe not. So with same kind of thing, you have to take these kinds of findings and associate those with your patients on whether or not it seems a legit presentation or if this is kind of the normal behavior, okay? Then your heel to shin, okay? This is the fun one that I love to watch people try and do. So you got somebody sitting there, they're in bed, something like that. So you're like, hey, what I need you to do is I need to take your right heel, touch it to your knee, and scrape along your shin down to your foot. So just like this. So you come up here, touch it right here, and then you slide down. Okay? Same kind of thing. You're trying to have this little... Right. Can't, yeah, okay, yep, we're good, right? So what you're trying to do is you're trying to look for this, even them getting to here, right? Because now they're trying to cross hemispheres of the body. So now they're trying to come across, and now they're like, okay, and then trying to get a smooth down, right? So a lot of times what will happen is you'll get something along the lines of this, right? Is that a positive finding? Absolutely. Once again, we go back to the 90-year-old female that can't hardly lift her legs already, right? So you have to take every one of these types of findings into account with your patient, right? So you do both sides, right heel to left shin, left heel to right shin, okay? So these are assessments you guys are going to start doing on each other as we start doing some stuff, okay? Oh, C-stat, finally. Here we go, Mark. Okay, so you got your C-stat alerts. So these are large vessel occlusions in the brain, okay? So you'll present, so you have a scoring method to create a C-stat positive. Conjugate gaze. Conjugate gaze is what?
Staring off.
Boom, right? Fixed. Oh, it's freaky, man. It's freaky the first couple times you see it. Like, you'll have somebody that's totally gorked out, you open up their eyes and it's just like, "Brrr." It's like, oh, this person's sick, right? So with a conjugate gaze, you will automatically score 2 points. So you have a conjugate gaze scoring at 2 points, you automatically are a C-stat positive.
You're a winner.
Huh?
So you're a winner.
Winner, winner, chicken dinner. Here we go. Right? So you automatically are a C-stat positive. So that changes your entire, so now instead of just a normal stroke alert, it calls in additional resources at the hospital. Have you guys been in there for a C-stat alert yet? Anybody? No? Alright. So it's a significantly bigger deal at the hospital when you have a large vessel versus a regular stroke presentation. Alright, so then you have 2 additional ways to really score points. You have your GCS type of points, right? So ask them how old they are, what month they are. They have to be oriented, right? If they can't answer those questions, you're scoring half a point, okay? And then so half a point here, and then follow commands. Hey, I need you to do this, I need you to hold this. So you're gonna find that out as you're doing the rest of your stroke assessment. Hey, hold your hands up. You're gonna know whether or not they can follow commands in that sense, okay? So you got half a point here and half a point here, okay? So if they can't follow commands and can't talk to you right, they're not oriented, that's 1 point total, okay? So you have 1 point here, 2 points here automatically, and then down here your motor. Can't hold arm drift. If they have a positive arm drift, that gives you 1 point, okay? So now, we have to score 2 in order to get us to a C-stat positive. So you would have to have unable to orient, unable to follow commands, and an arm drift in order to qualify for a C-stat positive if they don't have a conjugate gaze. Does that make sense? So half plus half plus 1 plus 1 plus 2 equals 2 and 2 and 2, right? Good? Everybody good with that? Piece of cake? All right.
It's just age and month.
It doesn't really matter age or month. Tell me your name, just the orientation.
Your LOC.
Yep. LOC.
If their LOC is less than 3 or less than 4, they get a half a point. Is that what you're saying?
Yeah. So if they can answer these, then there's no points awarded. Okay. If they can answer the questions, no points are awarded. But they can't follow commands, then that gets you half a point.
Right.
So you would have half a point here, and then if they have an arm drift, then that would be another 1. So you'd be a 1.5. Doesn't get you to the C-stat
The
positive.
conscious
stroke
commands and motor arm are things you pretty much find out
Very quickly.
very quickly.
Yeah. So, like, this is something that you're gonna see probably immediately, right? So this is the go-to, like the easy one, because we're always checking pupils now because you guys are so good at making sure I can't trick you, right? So boom, yeah, you're checking those pupils on unconscious unresponsive, conjugate gaze, be like, whew, okay. I'm gonna try a couple other things, but I'm already thinking
Code 3.
C-stat stroke, right? I mean, can overdoses present with
Yes.
conjugate gazes? Absolutely, right? So now you're gonna start to do a little bit more of your investigation into the history of what's kind of going on, that overall patient presentation. Yeah.
Is that so for asking the questions, is that they don't know the answers or they can't physically like?
Either one. Either one. If they don't know the answers or they can't physically get out the answers, they're unable to do that.
Okay. But if you were like, if someone was like in the room and they're like, she's 78 or whatever, and you're like, are you 78? And she goes, what does that count as?
That's just a poor way of asking a question, right? So if you're trying to figure out answers like this, you're asking questions that she's not hearing the answers to already. They have to come up with the answers to give you the information, right? So there's a lot of times you'll be like, hey, I really appreciate your help with all the information, but we need her or him to answer these questions so that we can kind of tell where we are with her.
What are you doing for someone whose baseline is questionable if they could answer age or month?
Then you
Then they still get half a point, but you're depending on the other.
the other underlying conditions. So say I got somebody coming from a care home or something like that, that they have Alzheimer's or dementia or something where having these questions isn't really adding up, right? No conjugate gaze, but they got the left arm drift.
Yeah.
Right, so boom, I got this, and I got like half a point here. You can't follow commands, but that's normal for them. I'm not gonna put them into this if it's a normal thing. It's a new onset of symptoms
Yeah.
associated with these things. That's when I would start to give them points for it.
Doesn't mean they're not already a stroke. It doesn't
Right.
mean you're already gonna do stuff, but you just don't meet the C-stat.
Yeah.
Alright, so this is your emergent large vessel occlusions. They go in, do a thrombolectomy, big time significant. So you can see that it's a significantly more of an invasive procedure, so that's why they want more warning, quicker access to be able to deal with those. Okay.
We call for air transport?
Yeah, so if you're long transport, because this is one of those time matters kinds of things, and so those are the things. All right, so a couple things. So onset symptoms of 6 hours or a wake-up stroke becomes a stroke alert. And when you call in, you need a name, age, date of birth, and ETA. These are questions that we're gonna start asking you guys in your scenarios. When you guys are gonna call and do stroke alerts now, because we're gonna maybe not have stroke alerts in your guys' scenarios, you guys are gonna wanna know this bit of information. Okay, name, age, date of birth, and ETA. Okay?
And last seen well?
Yeah, and military time, right? So it's gonna be like your onset. So if you're gonna call in, you'd be like, hey, Dr. Paulson, this is Kris on Med 2, coming in with a stroke alert. Presentation was 2 hours ago, left side arm drift, got some facial droop, yada, yada, yada. And I got a name, date of birth for you whenever you're ready. They'll be like, oh, stand by one, and then they'll get the paper. They're like, all right, go ahead, give them the name, give them the date of birth, and then ETA, and they'll be like, all right, cool, we'll see you when you get here. I'll go ahead and call that in on a radio report so the charge nurse knows you guys are coming. It's like, cool. So that's how quick a stroke alert is.
So then you call in twice?
Yes. Yeah, just so that in case Paulson doesn't communicate with the nursing staff, you don't roll in with a code 3 call and all of a sudden they're not quite ready, right? Most of the time, they're Johnny on the spot and they get that information over, but.
Will you make that second call? Do you say, I've called in with a
Yep.
stroke alert,
Yep.
and we have?
Yes, exactly. So I would start it off, hey, this is a stroke alert I talked to Dr. Paulson about. This is the 77-year-old male presented with left arm drift and facial droop. These are our vitals. These are what I did. Hey, see you in class.
Cool. And then you hang up before they ask.
Yes, boop, 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 gone, right? No questions, right? All right, so as you transport, elevate the bed 30 degrees so you don't increase more pressure on the brain with them laying down. Treat hypotension aggressively for cerebral perfusion, right? So if somebody's stroked out that bad, you want to make sure that you're continuing to perfuse and not allow them to completely decompensate. How are they going to present if it's a hemorrhagic stroke, you think? ICP, right? So depending on how bad the stroke is, or the hemorrhagic stroke is, it's just like a trauma, right? It's just like ICP. The bleeding is inside the cranium. It's just going to bleed and bleed and bleed. And you're going to end up with massive hypertension. And what's the heart rate going to do?
Drop.
What's it going to do initially?
Raise.
Right. Cool.
Almost like you here for yesterday's lecture.
Yeah.
That's amazing.
Oh, you guys talked about it yesterday?
Oh, in depth.
Oh, cool. All right, so you need family member names and contact information as well. Because what's gonna happen is the doctor's gonna wanna maybe contact them in regards to like last wishes, what do they wanna do, how do they wanna handle this, for patients that may or may not be towards the end of their life cycle that have presented with the stroke.
The hypotensive, treat hypotensive aggressively for cerebral perfusion. If we're thinking increased ICP,
But you're not always in a stroke,
okay,
right? Those
And
are only hemorrhagic strokes.
hemorrhagic strokes. And then if we have that hypotensive, do we aggressively treat it up to 80, 90?
I would say 90. I would
90?
try and keep it nothing more than 90, kind of like all the rest of our pressures. 90 is our good cutoff on where we're gonna shoot for those.
Okay.
Okay? Talked about the blood thinner usage, right? They want to know. They want to know whether or not the person's on blood thinners.
If a pediatric patient presents with stroke symptoms, are you assuming that it's hemorrhagic?
Yes. I mean, you're always assuming hemorrhagic until proven otherwise, because what's worse, hemorrhagic or
Hemorrhagic.
ischemic? Hemorrhagic, right? So you're always assuming worst case scenario. And so a lot of times if you have somebody that's having a hemorrhagic stroke in a pediatric, they're more than likely probably going to have some sort of seizure presentation initially. And so those are the types of things like, you're going to have your hands full and you're going to be really, really busy with this patient.
For this pediatric, the wrist?
Proximal, right? So you want 20 gauge proximal wrist, okay? You want ultimate,
Proximal to wrist, okay.
yeah, proximal to the wrist, right? So you want something from here to here, large enough because they're gonna need CT contrast, okay? And so preferably 18 in the forearm is the ultimate go-to in strokes. Nothing really, to be honest with you, we don't go with 20 gauges on stroke patient. We try and get 18 and higher. The other thing is you can go in the back of the hand with an 18 because it's a large enough cannula that you can actually push enough of the contrast through, right? So you can't go with like a small little 22 gauge. You can't go with the blue, can't go with the yellow, can't go with any of those colors. I know. Okay, so make sure you get it above the wrist. All right, here we go. 72-year-old female collapsed at home while eating dinner with her daughter. Oh man, you guys better be awake.
That's the big word.
Daughter, right-sided, hemiplegia. Oh, jeez.
Daughter?
Hemiplegia. Able to briskly follow commands with left side, follow commands with the left side, and able to answer questions. Those are your vitals. I see all kinds of cool stuff. Okay, what do you want to know? You guys ready?
Mm-hmm.
Are you guys awake?
Mm-hmm.
Okay, good. Because here it starts
Oh,
going.
God.
You guys are gonna have to be awake. Andrew, Josh, what do you got? What do you want to know? We're gonna go fast. We've got like 20 minutes. We got like 6 of these to go through. Faster. Oh, she take blood thinners. Andrew, do you have the ball? Yes or no?
Sorry.
Gosh, dang it. Last time I saw our normal was, let's see, if it's 10:30 now, it's our 8:30.
Again, I was gonna say blood thinners, but I guess that
Hey, Annalise.
past
Yeah.
medical
Say
history.
anything.
No.
Past medical history.
That's not good history. I take some sort of medication to help with my heart. Okay, so far we're like 2 for 3.
Pupils.
I'm dropping.
Conjugate gaze, is there, pinpoint?
Briskly follow commands. I'll give you a hint. If she can follow commands, she's not gonna have a conjugate gaze.
Good point.
Right? So conjugate gaze, somebody's gonna be completely, pretty much unresponsive, gorked out, kinda diminished LC. Michaela!
I'm looking at the screen. It's
Okay.
way over there.
You guys need to have a question ready to go. I'm like, you got a patient sitting in front of you that has these kinds of things.
Smile.
Like, we don't have time. What?
Can she smile
Yeah, she can smile.
evenly?
No, you got a little bit of facial droop.
Which side?
Let's see, what size,
side.
what starts with each one?
Left side.
Right side, so she's got a little bit of left side facial droop.
Any recent falls?
Yeah, I did. When? 3 weeks ago.
What's right side?
Fell down the stairs. Justin.
I'm gonna have the patient stay out their tongue straight forward.
Numbness.
One-sided.
No
Weakness.
deviation.
Weakness, numbness on the right side, but she can't move her left.
So cranial nerves don't all cross.
That's correct.
Do
So
arm
who's standing
drift
inside?
test.
Arm drift test. Which arm would you expect to fall?
Left arm.
Right.
What,
Yeah.
left hand, right?
Follow
Right
commands
hand
with
with left
left
side.
side.
Right-sided.
Oh, right side. He
Hemi.
teaches you. Right side.
Right side, so what would you expect, right or left?
Right.
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 History of AFib or recent surgeries?
Oh, what would make you think that I have a history of AFib?
Irregular.
I could, yeah.
Can you just wait your turn?
You never pass
So-
it to me anymore.
Woo! So, hey, you
I'm
remember,
getting a haircut today. So
remember
that's
that
good.
time when Justin just blurted
Oh
out?
my god.
5 seconds!
I feel like we're near that, okay? So, based on what portion of it was it that made you think AFib?
The irregular heart rate.
Absolutely, right? So as soon as you have somebody with an irregular heart rate, you should automatically be thinking, does this person have AFib, right? Okay, so yes, this person has AFib, and they take cortisone.
Can you get on my gurney so we can do the rest of this in the back of the ambulance?
No, I can't.
Can I help you on my gurney? So.
Oh, you want to stand me up?
I want to get you
wanna
on
try to move
my
me?
gurney and then do the rest of my assessment in the back of the ambulance.
Oh, okay. Hey, yeah, come on, here. Here, help me get up to get on your gurney.
Do you need help, Mark? I can help you.
Yeah.
We're doing it?
Wait, hold on. Yeah. Okay.
Where's the gurney?
Where'd you go,
I'm
Mom?
coming.
You offered my help.
I said I'm right here. All right, what do you want me to do?
All right.
So let's just look at
Under
it.
his-
I don't know.
It's not under his arm. All right.
Conjugate gaze.
Stand up first. Nice. Can you stand for us? Yeah? Okay.
Yeah.
Great. You can. So let's just pick him up and get him on our gurney.
Oh, jeez.
All right.
So,
I know. Are you experiencing any dizziness? That sort of thing?
yes.
I don't even care.
She's on the gurney.
Yeah.
But we're moving, and I'm
Well,
doing the
so-
rest of my assessment.
So let's
in the
back up.
gurney.
Let's back up just a little bit. So you got me on the gurney, great, right? What do you want to do? Like, what would help you in making that determination on getting me to the gurney?
Quick Cincinnati.
Quick Cincinnati, right? So you can do quick arm drift kind of thing, right? So obviously, if we have this right side, we probably figured something out, right?
Yeah.
We did some sort of assessment to get there. But anytime somebody has right-sided arm paralysis, what's very common to go along with it?
Right, so leg paralysis.
Right leg paralysis too, right? So you'd be like, hey, let's stand you up. You'd be like, okay, woof, right? If you're not expecting it, that's how people get hurt in the pre-hospital setting. It's like, oh yeah, you just expect them to naturally bear their weight. They don't know that there's something. They don't know what's going on down there. They don't know if it's good or bad or what. You go stand them up. Most elderly people, can they bear their weight with just one leg?
No.
No, so you're gonna get them to about here, and they'll be like, boom, and down they go, right? But you have a hold of them, so now what happens? What do you do to try and avoid them? Yeah,
And you're not in a position to.
right. You're not
support
totally
them.
braced, ready to go, and so a lot of times, hey, they start to go down, so you automatically go like this, and you end up hurting your back, right? So, all right, so yes, I got right side leg weakness as well. Can't bear it, can't move it, can't feel it, can't do anything like that. Levi, pay attention! Oh man.
He caught it.
Now what? Oh.
And we're in our rig now.
Oh, yeah, we're on this fancy gurney here.
To our, like.
30 degrees.
Knees and those tests.
I don't know what those tests are. Did you already talk Blake?
No,
Yeah,
I'm
no,
just,
I
didn't.
I'm just stretching.
Have you had this happen to you before? Have you had TIA maybe?
I've never won TIA before. Just one.
It's a big one.
Just one.
Chad. You know what? We're taking a long time on one patient.
We could put some 18s in there.
Okay, if I got right-sided paralysis, what do you think is gonna happen on my right shoulder? Okay.
Is that what happens?
Yeah, that's exactly what happens. Did you have something?
No, I'm touching my hair.
Oh, display it. Okay. Okay, so what do we think right now?
Touching my hair.
Shut up.
Hemorrhagic.
Did you go to the doctor when you fell down the stairs?
Right, down.
How many stairs?
Great question. It's like 8 stairs. Yeah.
Did you slide down or did you fall head first down?
Oh no, I like Superman.
Where did you
Superman
fall from?
down the stairs.
Do you have a headache?
No.
Is this third speech normal for you?
What floor is we?
Yeah, that's normal.
I showed up to school and intoxicated this morning. Sorry.
That's a
Is
dog.
that what it's like?
All right, so yeah, so family member says, yeah, this is not normal. None of this is normal presentation. What are you guys thinking? Is it a stroke alert?
It's not a C-stat, but it's a stroke
Yeah.
alert.
Not a C-stat. Why is it not a C-stat?
Because there's no conjugate gaze and they're not confused.
I'm not confused at all.
She's able to.
They seem to be answering questions appropriately.
Didn't get to you.
Did you guys ask?
No.
Like orientation stuff?
But you've been answering questions, and as opposed to the 3-week fall and what happened then.
How do you know that the 3-week fall is accurate?
Talk to the doctor, check the doctor.
There you go. So you gotta get confirmation on the history events. Because just because somebody says something, doesn't mean that it's
Absolutely.
accurate. So you gotta try and, so obviously as you're questioning somebody, you're gonna kind of pick up on whether or not they appear oriented or not. And anytime you end up with some sort of stroke alteration, you kind of slip in those like alert and oriented questions like, hey, what's your name? Can you spell your name for me real quick? That kind of gets that going. It's like, so where are we at right now, right? And so you don't want to be out there like walk up and be like, hey, what's your name? What's your date of birth? Da, 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 like right off the bat, right? I told you guys about my probie that was doing that really bonkers, right? Okay, so don't we do a stroke alert?
Yes.
Yes. All right, number 2. 48-year female presents to the EMS with worst headache of her life. Oh, son of a bee. States that the pain is the worst in the back of her head and neck. Has a history of hypertension, non-compliant with her meds and tobacco use. Vital signs 174 over 88, heart rate 103, stats 99, room air, respiratory rate 22. Questions, go.
What's your name?
Yes.
Mrs. Lincoln.
Mrs. Lincoln.
Your name.
Mrs. Lincoln.
Can you spell it for me?
Yes. L-I-K-E-N.
Daughter, is that correct?
Huh?
Is that correct?
Yes.
How long ago did the headache start?
Yeah, I woke up with it.
What time is it?
Woke up 3 hours ago. Let's go, James. Speed.
You having any other issues with vision, or
I don't know what issues are, young man.
Are you able to see? Are you having blurry vision?
No, my vision's great.
Have you fallen recently?
No.
What are you doing before this happened?
I was watching Days of Our Lives.
You were asleep
Yeah, you're
watching Days of Our Lives?
Yeah, I fell asleep watching it.
Last night?
Well, I don't even know what that is.
It's this morning. I don't know, is Days of Our Lives come on?
Yeah, you
anymore?
can slide.
Yes.
It's in the
I don't
lobby.
watch it, but
Is it? I'm sorry. Sorry.
She TiVoed it.
Yeah, DVR, there we are. All right, what do we got? Where are we going?
12 weeks.
We have all of our stroke assessment that we could do.
You said to
and we-
make sure to do a
and we
cardiac
choose the 12 lead
exam.
right now.
Can we do the fast test?
Fast test.
The arms out.
Okay,
Show me
yeah.
all close your eyes. Can you hold it for 10 seconds? Hold, hold, hold. Alright, can you go ahead and put them down?
Oh, thank you.
Can you show me all your teeth? All of them.
That's all I got. Lost all my meth mouth is really,
Can you say?
No.
Cincinnati?
I don't know Cincinnati. I don't like the Bengals.
Can you repeat right after me? Oh, I just shot Carrie out my mouth.
I just shot
Okay,
Kayla.
last one,
Rose.
and then I'm gonna physically remove the ball from you.
Can you say the phrase exactly?
Exactly.
It's always sunny in Cincinnati.
It's always sunny in Cincinnati.
The finger, your nose, and.
Well, come on up here. Let's go. If you want to do a test, you guys gotta get up here and do it. Let's go, Allie. Next question.
Have you ever had this headache before?
Never in my life. This is the worst headache I've ever had. Ever. Ever. Oh, what do you need me to do?
Alright, so don't move your head. I want you to take finger to nose. Your finger, not mine. Your finger to your nose. And then from that to my finger, okay? Okay, nose, finger, nose, finger, nose, finger,
Don't move it so quick.
nose, finger,
Nice.
nose, finger.
No, you just moved your head. You cheated.
Getting out of the leg, we're gonna throw that. Okay, anyone else
Are you
notice?
done? Are you
Yeah.
done? All right.
I wanna
have a
do
seat.
it with the other side too.
Oh, okay, let's go. Let's go. Speed,
Same
determination, speed.
Finger. Okay.
You're cheating
Stop moving your
again.
head.
You didn't give me any rules.
C-spine.
Finger, that hand.
I think he passed. I think he's.
But on the crossing over, he missed it.
Hurry up.
What? I don't. Do you take any Coumadin or?
Thanks, Rapper.
Coumadin. Coumadin.
Coumadin, sorry, not
Coumadin, cumin on your No. Oh, there we go.
Open your eyes wide, close them tight.
Is that what's happening?
Huh?
I can't tell.
All right, what do you guys think right now?
Who knows what that was?
I don't know.
Can't tell.
Still, I was.
see what that is.
Okay, first question, stroke alert, yes or no?
So you have any blurred vision, because it's in the back of your head.
No blurred vision.
Hypertension headaches present with head in the back, so could be that. If we're trying to rule out stroke
So-
first.
We didn't do all the
She didn't
cranial
do
nerve.
So, have you guys completed everything that you want?
No.
The whole
No, what
cranial
else you
nerve
want?
test has not been done.
The whole what?
The whole cranial nerve test
Yeah.
hasn't been
Oh,
done yet.
and what else have we not done?
You didn't raise your
Eyebrows.
eyebrows.
You didn't say ah.
Okay, so you guys complete